I'm John Cooke. I'm the chair of the Department of Cardiovascular Sciences and director of the Regenerative Medicine program at the Houston Methodist Research Institute. I'm your moderator today. We have some excellent speakers. I think this is going to be a wonderful session. We're going to start off first with Karl-Henrik Grinnemo, who is here from Stockholm. He is a senior researcher at the Karolinska Institute. And his interest is the characterization of stem cells, cardiac stem cells, embryonic stem cell derived and cardiac progenitor derived cardiomyocytes. And he is a cardiovascular surgeon. He directs the heart transplant program in Stockholm and is developing an advanced heart failure program. So a clinician and scientist that is going to talk now about the evolution of stem cell therapy for cardiac disease. Karl-Henrik?
Thank you. Do I have this product?
Hey, Josh, come on up.
Yes, so I'm going to start out here talking about utilizing stem cells in effective treatment of heart disease. And I'm actually going to take you on a trip actually from the evolution of cell therapy from more than a decade ago to where we are today and perhaps some future directions there. So as I see it, to have an optimal stem cell for heart regeneration, there should be some characteristic of these cells, actually, especially when you implant into the heart. These cells should be safe. They should not give rise to any tumors or arrhythmias. They should be well tolerated by the immune system, which means that you can give them as an allogeneic source from another donor. And you can have an off-the-shelf system where you actually test the efficacy before you transplant the cells. They should be able to stimulate angiogenesis. They should be able to stimulate the inborn angiogenic capacity of the heart. Also cause homing of cardiopregenitor cells into the myocardium and also be protective for the myocardium itself. They should also be able to contribute to the vascular and cardiomyocyte pool in the myocardium, and that's the sort of the future directions. And the delivery should be very safe through minimal invasive methods. The stem cell therapy has evolved over the years. From the beginning, we wanted to actually transplant already prepared myocytes into the infarcted region. Today, we are working more on stimulating the endogenous capacity of the myocardium. And I think the future directions would be sort of a combination of these two and delivered through very safe, minimal invasive methods. We all started up for more than a decade ago with the skeletal myoblasts. This was a PI for these trials were Philippe Menachet in Paris. In the MAGIC trial, the patients were randomized to receive 2 different doses of skeletal myoblast or placebo control at the same time as a patient were undergoing coronary artery bypass grafting. After 6 months, you couldn't really see any effect of the myocardial function, and there was also a high degree of early postoperative ventricular arrhythmias, and this sort of ended the story of the skeletal myoblasts. A new strategy for implanting myoblast or myocytes into the myocardium was presented quite recently by Laflamme-Murray's team, where they used human embryonic stem cell derived cardiomyocytes and implanted these cells into the infarcted myocardium of non-human primates. After 2 weeks, you can see quite extensive engraftment here in the green cells, which are engrafted and actually form gap junctions with the surrounding cardiomyocytes. In this small trial, they couldn't actually see any effect of the ejection fraction, but there were some drawbacks actually. Quite high frequency of ventricular tachycardias, especially during the first 2 weeks after implantation. This together that you need actually immunosuppression, and there will always be a risk of getting tumors working with human embryonic stem cells, might limit their clinical use. So what are we working with today actually? Yeah, today we're working with stem cells that mainly produce factors that influence the survival of the cardiomyocytes that inhibit the apoptotic process, stimulating the angiogenetic capacity, and also stimulate neovascularization. The first stem cells to be used, or second generation of stem cells, were the bone marrow mononuclear cells. They've been used extensively for more than 10 years, trying to treat patients after myocardial infarction. And they were mainly given as an intracoronary infusion. Their effects were actually very, very limited. And now we are focusing more on this kind of cell, the mesenchymal stem cell, a subfraction of the bone marrow cells. And they only constitute about 0.01% of the cells in the bone marrow, but they can be highly expanded and very easily implanted into the myocardium. And I will continue my talk focusing on the mesenchymal stem cells and also how they relate to the cardiac perimeter cells. The mesenchymal stem cells, they can be given as an allogeneic source, and they've already been used in different kind of trials, trying to treat graft-versus-host disease, Crohn's disease, MS, and SLE, and so forth. And they were safe. They don't cause any immunosensitization at the donors. The mechanism of action of these cells is mainly of down-regulating the inflammatory response, acting through the macrophages, the neutrophils, converting effector T cells to regulatory T cells, which gets an inflammatory response which is not destructive. Instead, it's quite reparative. These cells also survive on the infarcted myocardium, stimulated to produce stem cell-derived factor 1, hepatocyte growth factor, vascular endothelial growth factor, and so forth. Factors which are important for neovascularization, stimulating angiogenesis, arteriogenesis, also homing of stem cells, and inhibiting apoptosis. So these cells seem to be quite optimal to be used in clinic. Another aspect is the route of delivery of these stem cells, because that will definitely affect the outcome. In the beginning, when they used the skeletal myoblast, these were injected mainly directly through intramyocardial injections at the same time of coronary artery bypass grafting. The second generation stem cells, the bone marrow mononuclear cells, they used the intercoronary route. And now we more and more focus on getting this transendocardial route, where they introduce a catheter through the aortic valve into the left ventricle, which gives you control and can direct the injection all over the myocardium. And this definitely affects the survival of the cells, which kind of route you use. This has been demonstrated by the Japanese team here, that if you give the cells intravenously or in the chamber of the left ventricle or intracoronary, you get a very, very low retention of the cells in the myocardium. While if you inject the cells directly intramyocardially or transendomyocardially, the cells will be there for at least 1 week. And they can actually perform the paracrine effect during this period. Allogeneic mesenchymal stem cells have been used clinically in patients with ischemic heart disease. Joshua Hare published this trial time ago. The Poseidon trial with the allogeneic mesenchymal stem cells were used together with autologous stem cells, different doses in patients with ischemic heart disease. What you actually could see was that during this follow-up of 1 year, there was a reduction in the scar size, and there was also an effect on inhibiting the remodeling process. So you reduced the end-systolic volume and systolic volume, sphericity index, but you didn't have any effect on the ejection fraction. The mesenchymal stem cells has also been used in more severely ill patients, patients in need of left ventricular assist devices for support of the left ventricular function. In the study recently published by Josef Wu's team, they randomized patients who were supposed to get a left ventricular assist device to get either mesenchymal stem cells together with the left ventricular assist device or just the assist device alone. What they did was that they checked actually for recovery of the left ventricle. And after 3 months, 50% of the stem cell treated group actually could effectively be weaned for more than 30 minutes. And in the stem cell treated group. And after 1 year, actually, the average time the patients could be off the LVAD were more than 65 minutes, which is quite impressive, actually, in these severely ill patients. We have developed a system now for delivery of these stem cells, even for patients who are already ongoing LVAD support. And this is development together with the company Cardio3 Biosciences in Belgium and the Mayo Clinic group and the Turching and Atta Behfar here. And as you can see, we can introduce the CCAT catheter through the aortic valve into the left ventricle in this pig model, I'd say. And here you can see the inflow cannula of the left ventricular assist device. And you can do the injections in the myocardium, and there is no risk for the catheter actually to go in through the inflow cannula of the pump. And with this technique, you can actually, perhaps you don't really see it that well, but you can see the blue spots here. We can actually cover the wall myocardium, the wall regions of the myocardium using this technique, even very close to the inflow cannula here for the left ventricular assist device. So finally, I will just make a few statements here for the future as I see it. And that would be that the stem cell therapy will be more like mimicking actually the characteristics of the cardiac preemptor cells. And there's one preemptor cell that is more characterized than anyone else, and that's the islet-1 positive cells. The islet-1 positive cells give rise to everything in yellow here, the right side of the heart, the first part of the aorta and pulmonary artery. And these cells are multipotent. And we have developed a method now for deriving these islet-1 positive cells from the mesenchymal stem cells. So from the beginning, you don't have any islet-1 expression at all. But during the culturing process, from 1 to 2 weeks actually, the mesenchymal stem cells switch into islet-1 multipotent stem cells, which in turn can differentiate into cardiomyocytes, endothelial cells, and smooth muscle cells. They can also derive beating cardiomyocytes, and could you please click on the green cell there? Yeah, you can see that you can actually get beating cardiomyocytes actually from these mesenchymal stem cells, and these are striated troponin T positive cardiomyocytes derived from mesenchymal stem cells. Another important characteristic of these islet-1 positive cells derived from mesenchymal stem cells are that they have a migration capacity. If you inject the cells in the left ventricle of a normal rat heart, they migrate to this region, which is the alpha tract region, the area, the first part of the aorta and pulmonary artery, where these cells are resident during the embryonic period and even in adult heart. But if you induce a myocardial infarction here by LID ligation, these cells migrate back into the infarction region where they proliferate. They also can find their way even through the intravenous route into the infarcted area. So after 1 week, you can see a massive infiltration of islet-1 positive cells, everything in green-blue here in the infarcted region, and after 2 weeks, the cells line up, starting also to express cardiomyocyte markers. And what you can see is that they have an effect on the myocardial function, that the ejection fraction actually goes back to normal in the stem cell treated group, but in the control group it still deteriorates. And it has an effect of the remodeling process inhibiting that. So finally, I will just finalize by stating actually that I believe in the future that the stem cell therapy be more based on mimicking the characteristic of cardiac preemptor cells, using their multipotent capacity. But if you can combine that with the immunomodulatory effect of the mesenchymal stem cells, that would be perfect. And delivery system through minimal invasive methods. And I just want to address a special thanks to my colleagues in the heart lab, especially Mattias Kobaccio, Cecilia Österholm, and Christer Sylvian, and my collaborators, both collaborators here at, from Mayo Clinic, and Sergei Rudin and Christian Ibarra, who has contributed a lot for developing the islet-1 positive cells. So thank you very much for your attention.
Thank you, Karl-Henrik. That was a nice overview. We're now going to go on to Atta Behfar's talk. Atta Behfar is assistant professor of medicine at the Mayo Clinic, where he received his MD PhD in pharmacology and experimental therapeutics. Dr. Behfar has done some very exciting work about modifying stem cells to enhance their function. We're going to hear a little bit about that now. Dr. Behfar.
Thanks very much. It's a pleasure to be here with you today. What we'll do in this talk is to review a very particular stem cell phenotype, and we'll essentially cover from the initial phase of looking at mesenchymal stem cells, identifying what works about them, what doesn't, and then sort of review with you how we changed their behavior and ultimately took that to clinical trial. I think Karl-Henrik's done a beautiful job of reviewing mesenchymal stem cell-based therapeutics for you already, so I won't really review that again. Go ahead to the next slide, please. So when we think about heart disease management, really the main focus of our group has been heart failure. And the reason for this is because really when you look at heart disease, ischemic heart failure is one of the biggest issues that we face today in the United States and in the Western Hemisphere. And when we, can you keep advancing the slide? Actually, go back, I'm sorry, it's not animated right. So when we look at the heart failure population, we have patients that come through the door. We initially give them drug-based therapies to try and palliate their disease. As they progress in their disease, we next offer them devices such as pacemakers to try and improve the synchronicity of their heart, to try to improve their quality of life. But they continue to progress in their disease, and as Karl-Henrik just highlighted, we then have to offer things like hemodynamic support devices or heart transplant to this population. And the way we approached stem cell biology is to see if we can really have this be a tool that is used in tandem with drug therapy or in tandem with devices that prevents this terminal progression towards needing artificial pumps or transplant. Okay, go ahead. And the initial concept was rather simplistic. We have a heart that's damaged. We have these cell populations that have this capacity to transdifferentiate into a variety of phenotypes. Why not put these cells in and see if they would replace damaged tissue or help repair damaged tissue to result in a healthy looking heart? And unfortunately what's happened, go ahead to the next, is that that hasn't really worked. In other words, although we get these anecdotal examples of great benefit, in particular in the earlier trials, a lot of the trials, in particular those that were done in the United States, showed pretty heterogeneous outcomes. In other words, a lot of the patients just didn't have the kind of response that we'd like to see to cell-based therapy. Okay, go ahead. So what we did at Mayo was to look at these stem cells fundamentally. In other words, we're taking cells out of a patient with heart failure and expecting these cells to be healthy even though the patient isn't. So we took a cohort of patients undergoing coronary artery bypass graft. These are patients with heart failure. We isolated sternal bone marrow, purified mesenchymal stem cells, and then put these stem cells back into models of ischemic cardiomyopathy. And what we saw was much like what we were seeing in trials. We saw a rare cohort of animals that responded to the cells. In other words, rare patients whose cells were regenerative, and the vast majority of patients whose cells did absolutely nothing. So a heterogeneous outcome, just like the trial. What was unique about this experience was that we could actually look at the cells fundamentally. We knew which cells were good and which ones were bad. And we could look and see what was different between these two cell populations. And indeed, what we found doing high throughput analysis, such as genetics analysis or protein-based analysis, what we found was that the cells that were reparative had the capacity to see the world around them. In other words, they were very responsive to the culture environment that they were put into. If you wanted to push them towards cardiogenesis, they go that way. If you wanted to push them towards bone, they would go that way. So they were very plastic still. Whereas the cells that didn't repair the heart were stuck being stem cells. In other words, they didn't want to really do anything but just be themselves. And so, go ahead to the next slide. And so we really wanted to understand how can we now take this non-reparative population of cells and make them behave like these rare reparative cells that we see in about 5% of our patient population. All right, next slide. And the reason we want to do this is simply this. If we have the capacity to know which cells are truly beneficial, we can select out those patients and simply treat them when they have heart failure. But then, out of a large cohort of patients in need, you only get a handful of patients that will genuinely show benefit. But if you find an approach whereby you can harvest cells from every patient, recondition these cells such that they conform to a particular potency profile, a particular phenotype that is associated with repair benefit, then you may be able to offer cell-based therapy to a broader population of patients, assuring that they'll also benefit. All right, next slide. And so that's really been the big challenge in the field. So we have this paradigm here where we have cells giving us heterogeneous outcome. Next slide. And we have all of these efforts now that are trying to figure out how we can go from this platform to optimizing outcomes using these types of technologies. And so there's a variety of things that you can do. You can combine this therapy with standard therapies that are offered right now in the clinical practice. You can condition the organ. In other words, you can condition the heart and offer different types of treatments to the heart, such as extracorporeal shockwave, to try to improve cell engraftment and cell function in the heart. You can try to select out very narrow bands of cell populations that you feel are therapeutic. And what we wanted to do with this experience of having cells that either really repair or really don't repair, and having this difference in phenotype, what we wanted to do was to see if we could actually take our stem cell populations from our patients and lineage specify them. In other words, put them through a conditioning environment such that they would achieve a regenerative outcome. All right, next slide. And these are the markers that we were targeting. NKX 2.5, TBX5, MESP1, MEF2C. These are all early cardiac transcription factors, all seen during cardiac development, and all were found in these rare reparative patients. In other words, the stem cells that we got out of the bone marrow of patients whose cells repaired had the capacity to express all of this. The ones that didn't repair, we couldn't get them to express these, and so we wanted to try to figure out how we could. Next slide. And so what we did is we went back to how the heart develops itself, with the hypothesis that if you take these senescent stem cells, or these stem cells from patients that have disease, and you try and put them into a youthful condition, they may actually regain their functional status. So if we look at embryogenesis, we know that one layer of the embryo, called the endoderm, signals to another layer called the mesoderm, and essentially pushes the mesoderm towards cardiac differentiation. We can recapitulate that artificially in a culture dish using embryo bodies. So we can get embryo bodies that have these little areas of beating, as you can see in this movie, that are essentially responding to the endodermal condition. But what we wanted to do was see if we could spike the endoderm so that it really became cardiogenic. Go ahead and advance. And what we found is that if we added different types of cytokines, the most robust being TNF-alpha, we could dramatically increase the potency of the endoderm to drive the mesoderm towards cardiogenesis. And so this gave us a very unique opportunity to look at what the endoderm secretes before this priming and after the priming, subtract the two, and find genuinely what is really needed for cardiac differentiation. Okay, next slide. And this is what we found. we found that these set of growth factors are uniquely expressed at high levels by these primed endoderms. And if we put these factors in with embryonic stem cells, we can drive them more efficiently towards cardiac differentiation. But also with mesenchymal stem cells, which we know are a unique population that's therapeutic, we found that if we slightly modify what the endoderm secretes and subject these MSCs to those growth factors, we can essentially create artificially a youthful environment for the MSC population. And when we push them in that sort of environment, we can finally get even the non-reparative patient cells to start expressing these unique cardiac transcription factors that we feel is essential for regeneration. All right, next slide. And so this gave us initially a very easy testable model, right? So you have a patient cell that doesn't repair, you put it through a conditioning paradigm, and you have a cell that comes out that's expressing these transcription factors that you want. You can take the same patient cells and compare them head to head and see which performs better, and that's what we did. The blue lines are before treatment and the red lines are after. Blue boxes before, red boxes after. The green is the rare reparative patient cells. We want to make sure that we don't destroy the rare reparative patient cells by putting them through this condition. At least preclinically, we were able to get enough evidence to show that these cells have this unique capacity to now repair, even though initially coming out of the patient's body they didn't. All right, next slide. So this allowed us to then go to the regulatory bodies, this was in Europe, and ask permission to do a phase 2 clinical trial, primarily looking at safety, but also assessing for efficacy signals. So in this trial, we harvested bone marrow from our patients, from the iliac crest. We got rid of all of the cells except for the adherent mesenchymal stem cell population. These cells are grown up, and then they're qualified as being mesenchymal stem cells using a predefined marker panel. Once we've qualified these cells as MSC, we then subject them to this lineage specification program, which means we put several growth factors, which is highlighted by this yellow solution. And what we can see is as these growth factors are left on these cells over the course of 5 days, the cells rapidly start proliferating and they start to express these cardiac transcription factors. The whole process takes between 5 and 6 weeks to grow 1 billion cells. These cells are then packaged and prepped for implantation into the heart. For delivery in the phase 2 trial, we used a percutaneous approach whereby the scar was defined in the heart, and then this percutaneous endocardial delivery catheter, meaning we go inside the heart and inject directly into the muscle, was used to inject these stem cells and deliver 1 billion cells around the scar. And then these patients were followed primarily for safety. This trial assessed feasibility of doing this. But also we had the opportunity to look at early efficacy signals, which I'll show in this movie, but also in the subsequent slides. So what we see is that over a 6-month observation period, we do get improvement in ejection fraction. The average was around 7%. And that was associated with a reduction in end systolic and diastolic volumes. And globally, what we saw was that these patients had a better exercise performance. All right, we can go to the next slide. So this really highlights then first-in-man experience using what we call lineage-specified cardiopoietic stem cells. In other words, these are MSCs when they come out of the body. We put them through a conditioning phase, and then we get this very particular phenotype coming out. we delivered, as I mentioned, around 1 billion cells, between 600 million and 1.2 billion cells. And we were able to get some of these efficacy signals. Next slide. We did also look at feasibility with this initial trial. And what we saw is that the main issue with regards to this type of therapy when you're trying to grow 1 billion cells is your bone marrow harvest. In other words, the times that we had failure to grow that many cells was because the prep of the bone marrow, harvest of the bone marrow, the cell quality coming out of the bone marrow was quite poor. So as we're progressing to more advanced phase trials, what we're really careful about is how we manage the bone marrow prep. Once we were able to get a sufficient number of MSCs and release the MSCs, we had full capability 100% of the time to lineage guide these cells over to the cardiopoietic phenotype. Next slide. And this is simply just going again over more safety data showing the different types of things that we monitored. In particular, arrhythmia has been a big issue in the field of cell-based therapy. And so what we wanted to do was ensure that in this very sick heart failure population, we weren't increasing the burden of either supraventricular or ventricular tachyarrhythmias, and we did not see that. Next slide. And then, as I mentioned with regards to efficacy, we did see some signals of efficacy in regards to ejection fraction. We saw a mean EF improvement of around 7%. Next slide. This was really primarily associated with a reduction, a significant reduction in end systolic volumes. In other words, the squeeze of the heart appeared to improve most dramatically, and although we did see some improvement in the diastolic phase, but not significantly. Next slide. And again, these patients did have this improved capability to walk, and in heart failure, we do monitor how well a patient can perform, and so what we saw is that they could walk about a football field length or so more than their than the control population in about 6 minutes. Next slide. And so what that's led to now is advanced phase trial. So we are planning on doing Chart 2 here in the United States. Chart 1 was started about 1.5 years ago. It is now about 200 patients recruited. We anticipate that early next year we'll be done recruiting this population. The efficacy data will be available to the DSMB sometime either late next year or early in 2016, and it'll be evaluated for futility and safety. And as that trial is underway, we plan on starting the Chart 2 trial both at Mayo Clinic and across the country. Is it time to go? Yeah. Okay. All right. Next slide. So really, as we move forward with cell-based therapy, I think we need to look at cell conditioning, cell phenotypes very carefully, and identify narrow populations of stem cells that can really be beneficial to our patients. Next slide. And so this is just to highlight all of the individuals that are involved in Chart 2, but also in all of the R&D that went into creating this cell population. Thanks very much.
Great job. That was very exciting. Thank you so much. We're going to move now to Josh Hare from the University of Miami. Josh is the Lewis Limburg Professor of Medicine and the Chief of Cardiology there, and also Director of the Interdisciplinary Stem Cell Institute. He trained at Penn, Johns Hopkins, and Harvard. He's got a great pedigree, and he's done great things for the field, and I'm going to let him tell us about the latest discoveries that he's been generating.
Thank you, John. I want to also thank the two previous speakers. I think this has been a terrific session, really focusing on how we can optimize strategies for clinical translation going forward. And the strategy I'm going to talk about this morning is combining cells to optimize their effects. If I could have the next slide, please. I do have some disclosures. Next slide, please. So the approach our group has always taken is the pathophysiologic approach. From the very beginning, when we entered the field, we entered it from the point of view of ventricular remodeling, and so our focus, like many of the other speakers, was on a more global effects of cell therapy rather than just cell differentiation. So as you think about the remodeled ventricle post-infarction, there's a large scar, and we have to focus on removing the fibrosis, perfusing it. We heard from other speakers about how the importance of neoangiogenesis. And then, of course, there's the issue of restoration of contractility. Should you be successful in removing that large burden of scar that has remodeled the ventricle, you would like to replace it with contractile tissue, which means that there's a requirement for new myocytes. Now, from basic science studies as well as translational studies, we recognize that there's two ways that can occur. One is a precursor cell can differentiate. That precursor could be the cell you've injected or an endogenous precursor that's been activated, and you can have a cell cycle reentry. And the last mechanism has now been convincingly demonstrated to occur in mammalians, but is lost as mammals evolve, not evolve, but grow up out of the neonatal period. Next slide, please. So I do want to make a few comments in this talk. I think this is an appropriate meeting to do that, is how we're being viewed in the, amongst our peers and in the popular press, because this is a very important issue for funding in the field. I would argue that the field is at a critical stage where we need to go into phase 3 studies, yet there's a lot of angst, if you will, in the field that perhaps we haven't done enough basic science. So there was a very an interesting article in the New York Times a few months ago, The Trials of Stem Cell Therapy. Hope and enthusiasm still abound, but they tend to outstrip the science, was one view. Next slide. And this actually led to some very, I thought, inflammatory comments. We live in an area of social media. These were comments by Benoit Bruneau, who's a respected scientist at the Gladstone, who said to the author of the article, "A trial that wasn't BS, sorry, but no, you don't find one." So I can only conclude and hope that he didn't actually read the couple of JAMA articles that we've had, because we've done very careful studies, and I think the previous speakers have shown some of them. And the field is clearly making progress. It's at a phase 3 stage, and so it's a little concerning that there are scientists who feel that it's all BS at this point and that these trials are premature. Certainly from the point of view of the patient population, which is just an enormous patient population with huge unmet needs, I think it would be very disturbing to halt trials because it's all BS at this point. Next slide, please. So here's a tabulation of what I would say is anything but BS. This is just a tabulation of human trials of mesenchymal stem cells or cardiac stem cell therapy for heart failure. The thing you'll note is that the trials are very small, but there is a nice totality of clinically meaningful endpoints that are emerging from these early trials. The 6-minute walk distance, which we heard about in the previous talk, is a very meaningful measure of how patients with congestive heart failure are doing, because exercise impairment is a fundamental marker of the heart failure syndrome. There's also a score called the Minnesota Living with Heart Failure Questionnaire. This is a widely accepted measure. It's used in clinical trials and is an accurate indicator of the symptoms that patients with heart failure have. And you also see a nice concordance of a reduction in the score, which is an improvement towards the better. The most important thing, I think, from a pathophysiologic standpoint is that all of these strategies do reduce myocardial fibrosis, which is incredibly important. It is the driving feature of the pathophysiology of the syndrome, and you see that on average in all of these trials is a 33% reduction in infarct burden, which in some but not all trials translates into an ejection fraction. So when I look at this data and I look at the N's, all under 100, a total of about 250 patients, my screaming conclusion is that the NIH isn't spending enough money on this, and that we have to move this forward as rapidly as possible into clinical trials, and hopefully that's what you see happening. The chart trials are a beautiful example of how that is occurring. Next slide, please. So this is, now going back to the science, this is the approach that we've used over the years in 4 different clinical trials. It's also an endocardial injection approach. We use the BioCardia catheter. I don't know if this is, which is a catheter that's got a helical needle at its tip. It can also be engaged endocardially at the border zone of the viable myocardium and the scar. Here's a cine angiogram from a patient where this is being done, and we can very carefully record where the injections have been delivered in the scar and border zones. Next slide, please. This slide depicts the effects of mesenchymal stem cell therapy. The bottom panels show the scar burden, and the top panels show tissue tagging, which is a measure of function. So this is a scarred area that has become scarred from a heart attack, and it's akinetic, as shown in the red. There's no contraction. 1 year later, after these injections, as shown in the last slide, we've reduced the scar by about 50% and restored that area to normal contraction. Next slide, please. This can be depicted by cine angiograms, and here you see the akinetic area, restoring function 6 months later, and near normal function 1 year later. So I think this is very, very effective and a very nice start for a clinical trial program that should proceed, not be considered BS. We have done a double-blind randomized study of this approach. I don't have the slide here, but it was published in JAMA earlier this year, where we actually randomized patients in a double-blind fashion to receive mesenchymal stem cells, placebo, or a bone marrow injection, and we were able to confirm these findings, that the mesenchymal stem cells reduce the scar and replace it with contractile tissue, and that leads to an improvement in 6-minute walk distance and an improvement in the Minnesota Living with Heart Failure score. Next, please. So obviously the issue is, can this be improved? And I think it's very important to understand the mechanisms of the restoration in contractility as the way to try to enhance this technology. So we've been very interested and involved in studying the endogenous repair mechanisms, the response to mesenchymal stem cells, and there are now several papers in the literature that show that the injection of mesenchymal stem cells stimulates endogenous precursor cells to proliferate. Not just that, but also that there's cell cycle activity. Cell cycle activity that's very reminiscent what occurs in a neonatal mouse if you transect its ventricular apex, and we've been able to show that that phenomenon can be recapitulated in an adult large mammal, as I'll show you in the next slide. There is limited engraftment of mesenchymal stem cells. It's not zero, but I think most in the field agree that it's about 1% late engraftment. I think that that 1% is very important, and if it was zero, we would not see the kinds of effects we're seeing. So there is, in this experiment, we've injected male cells into a female pig so we can track the Y chromosome, and indeed we see myocytes, medium-sized blood vessels, both with endothelial and vascular smooth muscle layers, small blood vessels, and reservoirs of immature cells. Next, please. Now, the thing that is very profound in these pig experiments is the proliferation of endogenous cardiac c-kit cells. So we see a massive upregulation of these cells. These are not the injected cells, these are endogenous cells. And there is the formation of gap junctions between mesenchymal stem cells, which we inject, and the native c-kit cells. Importantly, there's also cell cycle activity. You see myocytes undergoing cell division. Next slide. And here's another nice example of that from the pig, where we've also stained with laminin so you can outline the cell membrane, and you can clearly see this nuclear division occurring in this adult mammal. Next, please. So our findings up to now are consistent with the idea that endogenous mammalian repair pathways, known to be robust in the neonatal period, can be reactivated by mesenchymal stem cells in the injured adult mammalian heart. And so we have pursued this in a couple of experiments and have now developed a clinical trial around this observation. Next slide, please. So two types of experiments I'll show you very quickly in just a few minutes. We've performed a mixing experiment with combinations of cells. So we've taken mesenchymal stem cells with or without cardiac c-KIT cells, and if our hypothesis was that if there's this important interaction between the two cell types, this should manifest therapeutically. And in addition, we've looked using fate mapping to look at c-KIT cells in a very robust genetic labeled model. Next, please. So this is the cell mixing experiment. This is an adult pig now. We're tracking the infarct size with cardiac MRI, and we're injecting either placebo, either cell type alone, or the mixture. And indeed, what we see is that the mixture of mesenchymal stem cells and cardiac c-KIT cells has about a twofold greater reduction in infarct size reduction. Next, please. This is accompanied by, if you do detailed hemodynamic experiments, this is accompanied by a normalization both in systolic function and diastolic function. This is a control. You see a very depressed systole and a very steep diastolic curve, and these are completely normalized with the dual cell injection. Next, please. In the double injected animals, you see a 40-fold upregulation of the cell cycle activity. So we think that the combination further drives the endogenous repair mechanisms. Next, please. So we had developed a technique where we could look at this ex vivo. We could take a piece of heart tissue, culture it on a lawn of mesenchymal stem cells, and when we did that, we saw that the proliferation of c-KIT cells was about 5-fold elevated, and also led to a cell phenotype that had a greater propensity for lineage commitment to cardiac myocytes. Wanting to be further convinced, we redid this experiment in the next slide in a lineage traced mouse where we could genetically label the c-KIT cells as shown here. So this is a mouse piece of heart tissue. We can identify by treating the animal with tamoxifen for a few days. We can identify the c-KIT cells as green fluorescent, and then by doing the experiment where we culture them on the lawn of mesenchymal stem cells, we can see the egress of the c-KIT cells from the heart tissue as shown here. And this is dramatically increased by the mesenchymal stem cell co-mixture, and it also yields in culture contractile myocytes as shown here. So that was a very exciting finding. Next, please. So very quickly, in just a few minutes, I'll tell you how we've taken this now into a clinical trial that's FDA approved to do this in humans, to use the mesenchymal stem cells, mix them with the c-KIT cells, and see if there's a greater efficacy in pathophysiology and in measures like 6-minute walk distance and Minnesota score. So this is an alternative strategy, if you will, to that being pursued in the CHART program. Next, please. This will be conducted by the 7 centers of the CCTRN network as shown here. Next slide, please. And we have successfully developed a technique to isolate and expand the c-KIT cells from endomyocardial biopsies using a CD117 column. Next slide, please. Here are examples from a single endomyocardial biopsy, how we can amplify between 4 and 8 million cells in 20 to 40 days, making this applicable. And we hope to start this trial next year. Next slide, please. So in conclusion, in preclinical and clinical studies, bone marrow-derived MSCs reduce scar tissue by about 30 to 50%, now shown in multiple studies. The replaced tissue is unequivocally contractile, now shown in multiple studies. There's evidence for regeneration in the human heart, likely due to increased abundance of endogenous c-KIT cells and cell cycle activity. Lineage tracing studies now show that the MSCs clearly do activate endogenous c-KIT cells. They may activate others, but in our lineage trace, we traced for c-KIT. The interaction of MSCs and c-KIT cells form the basis for a novel therapeutic principle, that of cell combination therapy, and we're looking forward to testing that strategy in a NIH-funded trial that will hopefully start next year. Next slide, please. I'll just end by thanking a terrific team of co-workers and colleagues and trainees at the University of Miami, and a specific thanks to the NHLBI for their funding efforts. Clearly, we would not have been able to do any of this work without the SCCT mechanism and now the Cardiovascular Cell Therapy Research Network. Thank you very much.
Well, we just heard 3 wonderful talks. We only have about 8 minutes for discussion, so we're going to have a little discussion now. But because our time is short, I'd like to ask the speakers if you don't mind sticking around for a few minutes afterwards for additional questions, because I think you stimulated a lot of thought here. I'd like to start by pointing out that there is a thread running through these 3 talks, and that is the future of cardiac stem cell therapy may be in mesenchymal stromal cells, and that's what Karl-Henrik concluded at the end of his talk. And then we heard from Atta that modification of these mesenchymal stromal cells may improve their efficacy. And then we just heard about the exciting work that Dr. Hare is doing with the combination of c-KIT derived CSCs and MSCs, combination therapy. So one of the things that I found very interesting about the 3 talks is the idea that the endogenous MSCs in our patients with cardiac disease may be faulty, and that may be responsible for the reduced benefit of the therapy. So maybe I'll start with Josh. You're preparing to do this large study, concert study through the NHLBI. And do you have any thoughts about maybe looking at these cells for their replicative capacity or their differentiation capacity as Atta is doing?
Yeah, that's a terrific and obviously very important question. It also belies the question of whether allogeneic therapy is superior to autologous for that reason, because you can have a very tight quality control. We agree with the concept that that there's cell variability, and that there should be some attempts to look at biomarkers and try to identify what determines whether a cell product from an autologous patient would determine the outcome. I think much of that work has already beautifully been done by the Mayo group in their identification of certain features that lead to a more cardiopoietic mesenchymal stem cell over others. In our hands, in our trials, we were surprised that we didn't try to select for a specific type of mesenchymal stem cell, and in general, in a clinical population, had a positive response. We're recently just had a paper accepted at JACC that's looked at old versus young recipients and showed that they both responded to autologous therapy. So I think that the mesenchymal stem cells have a lot of promise, and I think that the culture expansion technique of the autologous cells enhances them, but certainly it's something that can be improved, and I think biomarker studies are the way to go.
Thanks. Yeah. And just to continue that thread, if I could have Atta just tell us, in the concert study that Josh is about to embark upon, do you have any biomarkers that he should be looking at to predict benefit of the autologous therapy?
Well, I think in the concert study, having this combo approach almost potentially may solve the issue through a different path. In other words, when you look at the cell cultures and when you look at the co-cultures between the c-KIT population and the MSC population, you actually see activation of these cardiac transcription factors that were shown. And so if we're looking at a youthful environment that will push these cells towards a more pro-regenerative phenotype, that can be achieved in recombinant form, but that may also be achieved through co-localization. And clearly, as we saw in the beautiful data that was shown, these factors are activated when the cells are put together. And so I think that there's a variety, our approach isn't the only approach, it's just the path we took. And I think that there's a variety of ways to optimize cell-based therapy, and I think as a collective, our field works pretty closely together to achieve this feat, and there's going to be a variety of different paths that are taken, and we'll continue to follow the field and see how it goes.
Thanks. And in the 2 minutes that remain, I'd like to ask Karl-Henrik and the others maybe to comment on the source of the MSCs. We've heard primarily about bone marrow-derived MSCs today. Doing a bone marrow aspiration on these cardiac patients, it's an extensive procedure. It's difficult for these patients. If it's done in the hands of a skillful hematologist, it's not too difficult. But what about using fat, adipose-derived mesenchymal stromal cells? Is there any benefit to that in terms of accessibility, or could there be some problems using adipose-derived MSCs?
Yeah, that's a very good question. I mean, it's been extensively used, and we've shown that mesenchymal stem cells from the fat actually has the capacity to go into neurocardiomyocyte phenotype 2. So of course there's a source, but what I also need to emphasize is that mesenchymal stem cells are not only present in the bone marrow, they are also in the heart and lung and so forth. And the nice thing with these mesenchymal stem cells are that they are sort of pre-specified for that environment. So if you have mesenchymal stem cells from the heart, they express early cardiomyocyte marker like the transcription factors. And I think that's because they are interacting with the resident preemptor cells also in the heart. But if you should use the bone marrow cells or the fat derived mesenchymal stem cells, we can't really answer that question right now. Actually, we know from that the bone marrow mesenchymal stem cells are more immunomodulating for the graft versus host disease, for example, and you can also see it in acute respiratory distress syndromes that the bone marrow derived mesenchymal stem cells are more downregulating the inflammatory response. But if they are more prone to be cardioparetic, but that we don't really know yet, I'd say.
Mm-hmm. Josh, do you have some comments about that?
Specifically about different tissues.
Well, you're using bone marrow-derived MSCs,
yes,
why not adipose-derived MSCs?
It is fascinating that, these are cells that were, 25 years ago thought of as the weeds, right? What the other unimportant part of the bone marrow. But yeah, I agree, they're widely distributed in just about every organ. I don't think he'd agree with me completely, but I think that the cardiospheres that Eduardo Marban is growing are probably cardiac stromal cells. They don't have all of the markers of a bone marrow mesenchymal stem cell, but they have most of them. They're CD105 positive to the same proportion. So those could very likely represent cardiac stromal cells, mesenchymal stem cells. The fat is an intriguing source because it's so rich in these cells. And again, the ability to culture them and use them as an allograft is there. I think the other tissue sources that should be mentioned are umbilical cord and amniotic fluid, other very important, early stage tissues that are very rich in these types of cells.
Mm-hmm. Well, thanks. I'm afraid we're going to have to end there, but our speakers will stay up if you have any other questions. Thank you so much for your attendance.